growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
So let's go back to last week. I was talking to you about how to turn a negative, downward momentum of your practice around quickly, and often why it happens. That was the focus of my podcast last week. I want to get back to that. So one of the things you heard me say is I became much more interactive with the team because I had laid back. I had put it on automatic pilot. Well, here's the takeaway I want you to think about right now. Sometimes, and some of you are not going to like this, so okay, I'm not running a popularity contest here. I'm trying to get you to believe in principles that I know work. Sometimes you just have to be the boss. I've been doing this a long time, and I did experiment in the beginning because I'm like a lot of you. I don't think I'm hung up on that we've earned the title of doctor. I don't even really know the psychology of what that means to me and others. But I can tell you that when I experimented with my team calling me by my first name, it made the line between me as the boss much thinner than I wanted it to be. And I don't think it went on for more than, I'm not even kidding. I don't even remember how it happened. I'm going back to my first year or two in practice. I'll say this to you. Your relationship with you and your team is unique. So far from me to be able to tell each of you how that should be. But what I am saying to you, when you have to be the boss sometimes with people that are your pals, that maybe you pal around on the weekends with, I try to remember all the holidays. I try to be sensitive to personal, different stories that all my team goes through throughout a year. I try to be a good listener. I try to be fair. But I'm clearly the boss. I'm clearly Dr. Rasner. And if I had to choose one easy thing for you to adopt, and are already calling you whatever your doctor name is, stick with it. Because when you have to become more of a boss, it's easier to do that. There is no doubt in my office that I'm in charge, that when I ask of you things I need you to do more, or things I've asked you to before, that I need you to do what you used to do, it's not a peculiar thing for me to come at you. It's not, because me being Dr. Rasner, the boss, is perfectly okay with my 20 plus staff members. So that's it. It's not about being bossy. It's not about talking down to people. It's being the leader. And remember something, I've always said this in podcasts, and I'm going to say it again. You have the most to gain and lose by all the energy required to run a lion-hearted practice. Because if you do, which many of you do, and you sustain the amazing gains in productivity and hence income, it would be foolish of you to split evenly all that with your team. You are the doctor for a reason. You sacrificed 8+ years, counting college, to become who you are. There's nothing for you to apologize for. You deserve the great majority of the increase in profits. Don't be foolish. And by the same token, if perchance one of these practices listening to me went south for any reason, you're not going to be borrowing money from your team to survive, nor should you, and nor should they ever put in that situation, even if they had it. So you're the leader for a reason. Number one, they want you to be the leader. Number two, you have the most to gain and lose. So there's no point when staff members stop implementing, as they do for me, protocols they were doing for a year or 2 or 3. Like, for example, soliciting Yelp and Google reviews and things like that. And then, okay, I don't hear it anymore. Do I have to remind you? And it's poor me. It's really how I feel at the moment. But feeling sorry for yourself doesn't fix anything. So I take a deep breath, I go out, and I recapitulate what I need my front desk team to do. I want to go over a case presentation aspect that you all may have thought about before. This is related to an email I received about a month ago. And it's a new listener, and he was asking about the software I use to organize the photos in my practice for case presentation. And do I have a recommendation? So I have very specific response to this, which is why I started with that, to be clear. And you'll be surprised how simple I keep it and make it. Here's what it is. Number one, I do think it's important that every one of you, if you haven't done it yet, invest in a high quality camera. And there's multiple places that'll give you recommendations. The AACD, I'm sure, has high recommendations, or very specific ones. They're not cheap. It's not a place for you to buy on Amazon or eBay. You need a quality, warranted camera. Number two, you or somebody on your team should take one of the online courses that are available to become comprehensive and professional in how you frame a right quadrant, a smile, a left quadrant, a face. I'm far from an expert on it, but I do have those standards down, and there's many courses online. So the Lion-Hearted Dentist, to be clear, clearly has a high quality camera. He also, or she, takes photographs on everything before and after. An implant, any aesthetic interior case, single crown to 12 units. Obviously, you want to document the pre-op. You want to document the bite. It is legal, protective, and sometimes can very often be used for future marketing. So we never really talked about this, I don't think, in any of my podcasts over the 2 years. It is a very important part of a quality office, certainly of a Lion-Hearted Dentist office. So again, you should have that. That said, this is how I present photographs in my office. This may be laughable to some of you. I really don't use a computer. I haven't studied the psychology of it, but there's a couple things I do in my presentation that you've heard me say. So when it comes to photographs, if it is an aesthetic case, we have, of course, I have the advantage of 40 years in practice. So we have many before and afters of various cases that may come into the office. Orthodontics with a drill, for example. Closing a little diastema. By the way, had a patient this week on Monday, wanted veneers because she lost her retainer after about a year and her teeth moved a little bit. This is a 30-some-year-old young lady that came to the visit with her dad as a sponsor for payment, assuming it was going to cost. And look, I know you know this. For goodness sakes, I know you know this. 1,000,000% of the time, you have to give the right advice. And very often, patients that seek cosmetic resolution to crooked teeth absolutely need orthodontics, whether you do ortho or not. I don't really do orthodontics. I do extrusion to attain a ferrule on a tooth that needs a crown, and that's it. There's times in my career I've experimented with it. It's not my thing. So I'll tell you that I said to the patient, I wouldn't dream of touching your teeth, and you shouldn't let anybody else do it either. Your teeth are beautiful. What you need to do is go back to ortho, probably take about 8 months to a year, and put the teeth back where they were, you could barely see it. I find it hard to believe that I have one listener that would have veneered those teeth. That said, there are cases that are acceptable, that have a small amount of movement required. Look, in my career of 40 years, I'm sure I violated the rule and thought that I was doing the right thing. You know, when you drill down a tooth, you better have thought it out. I mean, for full coverage. So I had before and afters of diastemas, orthodontics with a drill, like I just alluded to, where I thought it was appropriate. And we showed, and I am showing them a laminated before and after on an 8 by 10.5 piece of sturdy black construction, like cardboard. And on top of that, on the top is the before, on the bottom's the after. I'll show a redo of crowns. I think that's very nice to have in your arsenal. You know, an unesthetic porcelain fused to metal crown. We all get those cases every few years with a metal margin that the patient hates. Pretty nice to show them a beautiful after done in today's materials and with your technology and prepping ability that you've learned from the various teaching institutions. So yes, that's how I use photographs. I never, or maybe I have over the years, but I never bring in my computer with a little show before and after. I do also have in that library of photographs, which was about 15 or 20, I also have a bar for a implant overdenture. I also have that in 3D, by the way. So here's how I illustrate in my case presentations. I literally have hard copy before and afters, not on a computer. That's what I meant when I said, I don't know the psychology behind it, but to me there's something behind them holding it in their hand. By the way, I do the same thing with the 3D models that I use. So when I show a patient a denture, he still has teeth in his mouth, and he's considering going to a denture, I hold up the edentulous arch, which, by the way, I had copied and manufactured, if any of you don't know where to get one. Or make your own. Make it real clean. It can't be sloppy. It's got to look like you bought it at a conference or something. So it's an upper and lower model, articulated, with an upper and lower denture on it. Okay? And of course the articulator comes apart. So I said, have you ever seen a denture before? And I take a denture off and I put it in their hand. And I do the same thing with a partial. And I have about 5 different types of partials. Valplast, a flexible partial. I have a conventional partial denture with clasp. I have a flipper. I have a precision partial with crowns and a partial that slips, that's more aesthetic, into the precision attachments. So we have all that. And I'm literally putting it in their hand. I'm putting the model of the edentulous maxillary arch. And when I get to the mandible, it's easy for me to say, you see the difference here, sir, is on the bottom, what do you think else is there? Your tongue's there. And it's a problem. When you yawn, when you speak, when you swallow, there's muscles of your tongue that have a tendency to lift a denture that's not secured by implants. And I'm not here to tell you to put the fear of God in them. That's not what I'm trying to do. I'm trying to educate them, which is what we do. And I find that very effective with 3D models, with hard copy. I don't even use, although my staff does with recall, select cavities that maybe a patient can't relate to or calculus buildup. I don't even use the intraoral camera that I obviously have in every room. So that's what I use. And again, you may look at me And if you can do it better, then this podcast isn't about only doing it my way. If you think it's working for you, or just try my way and see. The third thing I do that's, I don't know, a little old school, is I hold a mirror. You can purchase at CVS or any other drugstore. I have one in every room. And I hold that in front of them, and it's a little bit of work to make sure they keep looking in the mirror. And I tell them, especially on an aesthetic case, I'll say, so this is what you can expect at the end. I'm going to change and cover from this tooth on your right all the way over here to your left. I'm not going to address this or that. There's literally a visual conversation at that point. So, hey, listen, I appreciate whoever wrote that letter to me, but that's the truth. I don't have a software. And over my career, I've had all kinds of expensive videos that show what happens when you, to the bone when you lose an implant, or what a root canal is like, or what a free gingival graft is like. And they're done beautifully. I get it. But there's something lost in the transition between your explanation when you go, in my opinion, to that type of reference to include in your case presentation. So keep it simple. Before and after photographs, laminated. Ask me to send you some pictures of them. I'll take some pictures from my phone of our before and afters. You know, I never thought of this, but I could have them copied for you. I'm not going to pay for them, but they're very effective. I have some face shots, before and after dentures. You know, a denture that's got a reverse curve of Spey, or a midline that's off, and what it looks like if you did it correctly. These are the tools I use, along with a myriad. Let me tell you something. Your case, in my opinion, very often is lost or accepted in the first 5 minutes of your presentation, assuming they have the funds to get to what you're recommending. In other words, you can turn them off. So that's why I always brush my teeth, wash my face, try to look professional. I wear a scrub with a surgical scrub on top of that all day long, because that's the surgery, how much surgery I do. When I'm seeing a new patient, I put on a white coat. Yes, I do. And I walk in and I look pretty fresh. And I'm pretty good at the conversation I think is required. We've been at this ad nauseum for a couple years of what I go over and what I say. I think that's where it's won and lost. I don't think you'll lose the case if you use some fancy software, but if you don't have really high case acceptance, I would experiment with live, a mirror, before and afters they can touch, 3D models. But it's really in your conversation. I find myself more than ever telling patients, listen, I told you when I first walked in the first couple minutes, I told you I am not here to sell you or talk you into anything. I want to make that clear. But I am here to educate you as to the possibilities for what you've come to me for. That's what I want to do. And if it works for you, let's get to it. If you need to think about it, think about it. And when I'm done with them, most of them don't want to think about it. Now, wanting to do it and being able to afford to do it, are really two different things. So, it doesn't always work out. But I've said this to you and I'll say it again. It's really important that you polish your case presentation skills so that when the patient leaves, even if they don't accept what you recommended, they have a good feeling about you and your office. They didn't feel you were pushy. They didn't feel you were trying to talk them into anything. They certainly didn't think you wanted to get in their wallet. I'll give you an example before I go. So when I have somebody come in for a second opinion, they say this. I was going to my dentist for years. He retired. You guys have heard of this. And I went to a new dentist, and he told me I had 12 cavities. I mean, I just was at my last dentist a year ago. And I'll say, okay, let me tell you what you can expect from me. The absolute truth. If I look in your mouth and I think you have not 12, but 16 cavities, I'm going to tell you have 16, and I'm not going to tell you have 11, so you'll like me more. In other words, I'm going to tell you the truth. Now, dentists do vary in their opinion of what a patient needs, so let me take a look and I'll tell you what I think. I mean, that's just an honest, great approach, So, this is making me think of all kinds of things, but, when you get that patient that came for a second opinion, and you're doing diligence to a comprehensive exam, remember that. I tell the patient in the very beginning, I don't use the name or word, comprehensive exam, but I always tell them, and I've taught you how to do this. I tell them the best thing I've ever learned as a dentist is a philosophy that's called what to do when. Because dentists are always in that moment. Like we are in the moment right now. I tell the patient, you came to me today. You have a specific issue. What is the right thing for me to recommend? Well, the right thing for me to recommend is to give you a solution that will work. That's simple. Sometimes I can make that very easy for you. And if I can, I'm going to. And if it really needs a tooth, it really needs a crown instead of a filling or whatever it is, then that's what you're going to hear. And if you talk with sincerity and you're forthright and you're earnest, people hear you. People get it. Hope this helped you guys. I hope you're adopting some of these things. Glad I could get back to your email, my friend who wrote that. You guys stay strong. This is the road, my friends. See you next week on The Lion-Hearted Dentist.